Hello, my name is Julie Verdier. Today I will be presenting the nurse approach of the reverse shoulder arthroplasty with BioRSA. Just a little bit of history. First with Jules Péan, who did the first shoulder prosthesis in Ivory in 1893 on a 37-year-old patient with tuberculosis. This was done in two stages. First, infected tissues was resected, and in a second procedure, the prosthesis was implanted. Nearly a century later, Charles Neer pioneered modern shoulder arthroplasty, developing the first reliable prosthesis with the goal of restoring normal anatomy. These are some examples of prior prosthesis. Paul Gramont's idea focused on creating a medialized, fixed center of rotation, centered around congruent articular surfaces, and at the same time lowering the humerus. In summary, Paul Gramont's concept was to improve stability with the fixation of the center of rotation with congruent articular surfaces, improve deltoid function, reduce shear stress and glenoid loosening, and finally improve mobility. However, some problem existed with his concept: loss of shoulder contour, instability, and notching posterior and anterior resulting in decreased rotation. The BioRSA bony increase offset reverse shoulder arthroplasty was developed in 2006 by Mr. Boileau with the goal of improving RSA. The original design used a symmetric bone graft which is harvested from the humeral head. The primary goal of this was to lateralize the glenosphere and the center of rotation in order to decrease humeroscapular notching, improve mobility, improve stability, and result in improved contour of the shoulder. The second design uses an asymmetric bone graft from the humeral head too. The reason for this modification of the design was to improve inferior tilt of the glenosphere and correct posterior and glenoid wear. Ultimately, this improves the overall orientation of the glenosphere. One of the primary indications for RSA is cuff tear arthropathy. This is defined as a rotator cuff rupture leading to superior migration of the humeral head followed by cartilage destruction. The clinical presentation is a shoulder stiffness with difficulty with active elevation and sometimes pseudoparalysis. The patient positioning is very important to do the surgery. In this, we do bead chair. What are the benefits of this positioning? We think the head near the level as the body is better for the hypotension control with lower risk of cerebral hypoperfusion. The free arm allows dynamic control with the shoulder of the table. This position is well tolerated by the patient. You can see the final setup for the reverse shoulder arthroplasty with the nurse in front of the surgeon, so she can give the instrument easily and be aware of this procedure. For this surgery, we need tables and of course shoulder drapes. Obviously, we need BioRSA, as it has specific instrumentation for obtaining bone grafts. And in this, we use Flex from Wright Medical, but this procedure can be done with the Equalis Reverse too. On this picture, you can see the implants that we use. Base plate diameter 25 mm for women and 29 mm for men with long peg of 25 mm. Glenoid sphere diameter 33, 36 for women and 39, 42 for men, adapting to base plate diameter 25 or 29. Also, we use a pre-fit stem with several inclination. For RSA, and B stem is always used, and reverse tray with different offset. And finally, the polyethylene insert for the reverse. Now I will talk about the surgical technique. We start with the deltopectoral approach. When humerus is dislocated, we place guide pin with the BioRSA guide. Next, we do graft trimming and drilling with the 3-in-1 reamer. We then cut the graft with the cutting guide and the saw, and we use the graft extractor to place the graft on our base plate. It's time to prepare the glenoid. To do that, we use the glenoid pin guide and we place the pin at 10 degrees of tilt inferiorly. Next, we perform the glenoid reaming with reamer in slow motion until we can see a smiley face inferiorly. We then remove the pin and reinsert it with an additional 10 degrees inferior tilt with the glenoid guide, and then we do the glenoid central hole drilling with the drill diameter 7.5, then 8.3 millimeters. Finally, we do pridey or glenoid drilling with the pin in order to create bleeding bone to improve healing. We insert the base plate with the bone grafts, and we fix it with 4 screws, 2 compression screws and 2 locking screws. Finally, we place the glenosphere. The next thing is the humeral preparation with distal preparation first. We use the starter hole to create the pilot hole and use progressive sounders until we determine the size of the medullary canal. Next, we do the proximal preparation with the punch guide corresponding to the appropriate size. Then we perform the metaphyseal compaction with the compactor locked in the B position, which is 132.5 degrees to match the humeral cut. Don't forget to use the pin for the retroversion of the humerus. We select finally the reverse tray offset depending on the compaction and the position within humerus, low or height, and we fix this position. But before placing the final implant, we prepare for subscapulary transosseous reinsertion with 4 no-resorbable sutures placed prior to final system insertion. This is the final insertion of the implant, the stem, the tray, and the insert. We close the dentopectoral approach with Polysorb 1 metric and the subcutaneous closure with Polysorb 2.0 metric. Finally, we place Steri-Strip on the skin, no need to drain. This is the final prosthesis with the lateralizing bone graft, the base plate with the screw, the glenosphere, the stem, the tray, and finally the polyethylene insert. Thank you for your attention.